Good morning. I will be presenting our case series entitled Skin Graft Review in Dermofasciectomy for Dupuytren's Contracture within 48 hours, Challenging Historical Practice. This work has been undertaken at East Lancs with Mr. Kennedy and Mr. Yunus. Dermofasciectomy was first described in 1962 as a method to decrease the recurrence of Dupuytren's, which despite mixed evidence, on balance is likely correct. Full-thickness skin grafting is used to cover the defect, which is especially useful overlying the proximal phalanx due to the superficial nature of the neurovascular bundle. In particular, traditional teaching dictates that the graft is not disturbed for a period of 5 to 7 days based on the stages of imbibition, which is passive absorption of oxygen and nutrients, inosculation, which is establishing a new vascular network, and complete full revascularization. At our center, patients were poorly tolerating the dressings due to the soiling and smell. In some cases, the patients were reducing the dressing themselves. Our specialist nurse, who reviews all of our postoperative upper limb cases, reviews all patients at day 2 post-op. This led to a crossover of the groups. Anecdotally, this was not to graft detriment and so was continued. This case series aimed to review outcomes of this change from traditional practice. A retrospective review of single-surgeon dermofasciectomy cases for Dupuytren's contractures were reviewed between April 2014 to February 2020. The MCP, PIP, and DIPJ angles were recorded in addition to patient demographics and follow-up. Failure was defined as presence of similar or worse contractures at 12 weeks follow-up. Graft failure was considered separately as complete failure or more than 20% of sloughing at graft margins, and recurrence as more than 20 degrees with 12 months. Patient satisfaction was scored and the URAM score was collected pre- and post-operatively. All procedures were carried out under loop magnification. After dermofasciectomy, which was conducted from the proximal digital crease to PIPJ or midpoint of the middle phalanx, a mepital dressing backing was used to trace the skin defect for grafting. This was applied to the glabrous forearm and the graft harvested with fenestration in situ with the 15 blade. The graft was secured with circumferential interrupted 5-0 proline. We recorded 54 digits in 44 patients, of which 5 cases were adjacent digits. These were a larger population of males with a mean age of 61 years. 26 of these procedures were revisions and 23 were primary. The Tubiana stages were 3 and 4, indicating the severity and aggressive forms of these diseases we are dealing with in this series. Of note, during these procedures, 32 required check rein and flexor sheath release, and a single patient required flexor sheath release only. URAM scores demonstrated a significant decrease in combined result and primary procedures, but a non-significant decrease in the revision subgroup. The mean post-op satisfaction was 7.7. 4 patients required revision procedures and 2 cases demonstrated residual PIPJ contraction without further intervention necessary. This diagram details the treatment outcomes of the cohort. There were no neurovascular injuries. 2 grafts failed, 1 with subsequent amputation. However, I must reiterate this was a diathesis in the revision scenario. 2 graft sites became infected and were successfully treated with conservative measures. 2 patients failed to maintain correction. 1 of these requested amputation. This was a diathesis and he had a contralateral amputation which was serving him well. Again, highlighting the severity of the disease in the series and our goal of preserving the digit. The other patient had failure of correction with revision dermofasciectomy. 1 patient experienced tourniquet-related blistering and another prolonged post-op pain which resolved without specific treatment. These photographs demonstrate the graft healing at 2 days, 2 weeks, 6 weeks, and 3 months post-operatively. In conclusion, we consider the practice of reviewing dermofasciectomy wounds with full-thickness skin grafts at 48 hours post-operatively does not affect graft survival compared to published and traditional literature. This allows early movement and custom splintage. We acknowledge the limitations of this series being retrospective, not comparative, and of a smaller sample size. We would recommend a further RCT to compare graft survival and maintenance of correction between early wound review and custom splintage compares to the traditional timeframes. These are the references, and thank you for your time and attention.